Good morning. I'm Amy Herring, and I'll be moderating this first session. As you've heard, one of our objectives today is to understand strengths, limitations, and opportunities of existing data that are used to assess obesity prevalence and trends. Our first speaker this morning is Dr. Cynthia Ogden. Dr. Ogden is an epidemiologist at the National Center for Health Statistics at the Centers for Disease Control and Prevention, where she oversees the analysis group within the National Health and Nutrition Examinations Survey, commonly known as NHANES. Her research interests relate to nutrition and, in particular, growth and obesity. Dr. Ogden.
Thank you very much. I'm delighted to be here. There's like 10 people in the audience. It's kind of, but I'm very delighted to be here, and I want to thank the committee and the IOM for inviting me to participate today. I'm going to talk about obesity in the U.S. and kind of minutiae of things that I think are really important to think about when you look at obesity prevalence data or trends data. So some of it might be relevant to what you want, but there's a lot of very, very detailed things. So to start with, there are a lot of sources of national data on obesity in the U.S., and I'm really going to focus my conversation today on national data. There's the National Health and Nutrition Examinations Survey, which is nationally representative of the U.S. population, and it contains measurements of the entire age range. There's the National Health Interview Survey, which is also nationally representative, but it has self-reported data on weight and height. There's the National Survey of Children's Health, also nationally representative, but with self-reported weight and height. And there's the Behavioral Risk Factor Surveillance System, nationally representative of adults in the U.S. population with self-reported weight and height. And the Youth Risk Behavior Surveillance System, which is also nationally representative, but of high school kids, and it's self-reported weight and height. There are other sources of information, but these are kind of the big ones that are representative of the whole population. There are the Pediatric Nutrition Surveillance System, which we've heard mentioned today, is not representative of the whole population of that age range. It's just low-income kids who participate in federal programs. So you've probably all seen this slide. This is data on the prevalence of self-reported obesity among U.S. adults from the Behavioral Risk Factor Surveillance System in 2013. And you can see the state-level prevalence estimates. And this is one of the great strengths of this particular survey, is that you can get state-level data, unlike where I'm going to spend most of my conversation today on the NHANES data. So, as I said, I'm really going to talk about NHANES. And I'm going to talk also about some things that are not relevant just to NHANES, but to all obesity-related prevalence estimates and trends. So the NHANES survey is a complex multi-stage probability sample of the U.S. civilian non-institutionalized population. And I say that it's a multi-stage probability sample. There are confidence intervals around all estimates. People often think that this point estimate is the exact number. It's not the exact number. There's some error around it. Only approximately 5,000 people are surveyed each year, so it's a small survey. It's a small sample. One of the great things, though, is that there are measured data. And there's a whole body measures component, an anthropometry component in the survey. And weight and height are measured among many other anthropometry measures of all the participants. And I want to point out that the actual measurements go from the scale and the stadiometer into the database, which is unlike many other surveys. And so the amount of error related to writing down numbers doesn't exist. I wanted to also point out, since the whole issue of biologically implausible values was mentioned, and I think that we've been working on some interesting studies on this, and we have seen people exclude values from Haynes because they think that it's biologically implausible. When all the Haynes values are actually compared to other measurements we have DEXA scans for some surveys, we have other ways of looking at those data to see if they are accurate. And in fact, many of those very big weights are real. But they have been excluded in some people's analyses. And so I think that the BIV, the biologically implausible value cut points we've used, may be too conservative in terms of what's real. And Haynes travels around the country with mobile exam centers, and so we have standardized measurements of weight and height, among many, many other things, for people who know and love Haynes. It's a source of great information for our country. And so I just wanted to show a few pictures of the mobile exam centers, and I hope that if you ever have a chance to visit the mobile exam centers, you do. All right, the survey periods. Haynes began as the National Health Examination Survey before nutrition was added, but weight and height were measured back in the 60s. And so the first survey was in the early 60s, 62, and that was only for 18 to 79-year-olds. And then there were two other surveys in the 60s that were for children, 6 to 11 and 12 to 17 years of age. And then nutrition was added in 1971, and so Haynes was born. And there was Haynes 1, 2, and there was a Hispanic Haynes and a Haynes 3. And I put these all here with the age ranges so that you can see that already you have kind of a limitation if you want to look at trends. You can only do trends to a certain point depending on the age range you're looking at. Starting in 1999, Haynes became a continuous survey of the entire age range. And so it's continuously in the field. Right now it's in the field. Every 2 years, data are released in the fall. So this year is a release of data, so that the 13-14 data will be released this fall. So I kind of I'm going to show this slide again, but I want to start off by saying here are some things that I'm thinking about and I would like to kind of answer and have you think about throughout the talk. What is the definition of obesity being used? I think we don't think enough about this. You know, it's kind of like, oh, we know what this is. But I think we need to go back to that for a minute. Are we looking at totals? Are we looking at subgroups of the population? And what's the sample size? And that's a particular issue for Haynes, but these two issues are appropriate for any kind of analysis that you're going to do looking at obesity prevalence or trends. When you're looking at trends, what year are you going to start at? Because we can always say, if we always go back to 1960 to now, we're always going to say there's an increase in obesity. And then what kind of test are we going to do? Are you going to do a linear test of trends? Are you going to do a quadratic test of trends? Are you going to use all the data, the whole data set, or are you going to take the point estimates over time and just use those estimates in a particular type, with a particular type of method? Are you going to do unadjusted trends? Or are you going to do adjusted trends? And so these are all different kinds of questions analytically you're going to ask and answer when you do a different study, do your study. So I have to show you some data from Haynes. You've seen the Haynes data already, but in 2011-12, almost 16.9% of children and teens were obese, and 34.9% of adults. And I do like to, I know that there's a slight focus on children, but I really do want to emphasize that, the prevalence is twice in what it is in children, twice in adults what it is in children. And if you look at the number of obese individuals in the U.S., there are more than 90 million obese individuals, and 78.6 of them are adults. So this graph shows the counts by race ethnicity. And although you all are aware there are disparities in prevalence by race ethnicity, but when you look at the actual numbers in terms of burden, and if you look at it particularly at adults, you can see that light green part, the light green part of the bar is non-Hispanic whites. And so there are more non-Hispanic whites just because of the demographics in the population. So even though there are disparities in prevalence, this is what it looks like in terms of actual population counts. So I'm going to turn to obesity definitions. So how do we define it? Well, obesity refers to excess body fat, as you all know, but we use BMI, or body mass index, as a proxy for body fat. It's not a direct measure of body fat. And that's weight in kilograms divided by height in meters squared. We use it for adults, we use it for adolescents, and for children. Now, BMI does not distinguish between fat and muscle. It's very highly correlated with fat, especially at the higher BMI levels. And it doesn't tell you about the distribution of the fat, and that can make a difference in terms of health risk as the distribution of the fat. And the cut points in adults, I know that this is all quite a review, but underweight is a BMI less than 18.5. Normal weight is a BMI between 18.5 and 25. Overweight is a BMI between 25 and 30. And obesity is a BMI of 30 and over. And there are different categories, classes of obesity. So we have class 1 obesity would be 30 to 35, class 2 is 35 to 40, and class 3 is 40 and over. And there's a little table here to show you some examples so that an individual is 64 inches and a BMI of 30 would be 174 pounds for that person. What about in youth? Well, it's a little bit different because there are no set risk-based cutoffs. So we just talked about these cutoffs in adults. They're just set. These are the cut points no matter who you are. And, but BMI does vary with age and sex. Anyone who's looked at actually the growth charts, you can see how BMI changes with age. And so we really use a statistical definition of obesity in children. It's based on BMI for age, and it's in comparison to a reference population. In the United States, we use the CDC growth charts as that reference population. Here's a picture of the boys' BMI for age growth chart. And underweight is a BMI for age less than the 5th percentile. Normal weight is a BMI for age between the 5th and the 85th. Overweight is between the 85th and the 95th. And obesity, as indicated by the red arrow, is a BMI for age at or above the 95th percentile. And extreme obesity is a BMI for age at or above 120% of the 95th percentile, although this is a relatively new thing that people have adopted, this definition of extreme obesity in children. So I want to say something about this definition. So the CDC growth charts are based on data that I just showed you. Remember, I showed you the list of the data from the National Health Interview Survey earlier in the 60s. Well, that's what makes up the growth charts. And so by definition, back in the 60s and 70s and some of the 80s, the data that were used for the growth charts, by definition, 5% of those kids are obese, just by definition. And I want to point out something that I don't think people think about very much. One, I don't think people realize that by definition, 5% of kids back in the day are obese. But the other thing is, the 5% is, so it's a sex and age specific. And so this is kind of a visualization of let's say we're looking at 3-year-old girls and 6-year-old girls. And this is our population. The first 2 rows are the population of 3-year-old girls. The second are 6-year-old girls. The 95th percentile of the age, that cut point was used as the cut point for obesity. It doesn't matter what that actual distribution looked like. It could have been that, in fact, if you'd measured the body fat of all the 3-year-old girls, that, you know, everybody had really low body fat, but the 95th percentile was chosen. Then the 6-year-old girls, it could have been that all the girls were actually very heavy, but it was the 95th percentile that was chosen. So there's actually, you know, when you make comparisons, remember you're kind of thinking about it in relation to that population back in the day. And this is something that people don't really think about very often. But I think it's important just to understand this in terms of the definition of obesity in kids. The other thing to think about is, what do changes in weight mean in terms of changes in BMI categories? Well, here's some examples of a girl who's 2 years old, who's 2 feet 9 inches tall. And you can see that as her weight goes from 27 to 28 to 29 to 30 pounds. Her BMI percentile goes from 75, 85, 92 to 96. So small changes in weight for little kids can make a big change in the BMI percentile. And that gets us back to what? The measurement issue. You want to measure the child well, especially those small children, because what if there's just a problem with the scale? What if the child had a lot of clothing on? And so you can have a big effect in terms of the measurement of weight on BMI in these young children. It's not so much with the older kids, but so I showed also a boy who's 10 years old, 4 feet 7 inches, and you can see a 15-pound range going from the 78th to the 94th percentile. So I just focus on the quality of the data. I'm always thinking about the quality of the data. And now, there are other reference populations. We use the CDC growth charts, but throughout the world, there are other reference populations that are used where the kids are compared to. So another very popular one is the International Obesity Task Force reference population. And a lot of studies will use this definition. These data are from Brazil, Hong Kong, the Netherlands, Singapore, the UK, and the United States. And in fact, the US data are the growth chart data. That's what's in here. This is a little bit different. It's still a statistical definition, but this time it's linked to the adult definitions of a BMI of 25 and 30. And so what that means is all the data, at age 18, the average value where the data were 25 or 30, that particular centile was chosen as the cut point. All right, so that there's more of this connection to the adult definition. And sometimes I think people have a hard time understanding that. So you just take the data, and at age 18, you line up the data, figure out where the where 25 is, where 30 is, and then what the centile is at that point, and then you just use that throughout the age distribution. Here's a comparison of the CDC and the IOTF cut points. And you can see that for boys, for boys and girls, the IOTF cut point for obesity, the IOTF 30, is actually higher than it is for the CDC 95th percentile. But the IOTF 25 and the CDC 85th are pretty close. They're pretty similar. So what does this mean when you're looking at prevalence data? It means that if you use the IOTF definition, the prevalence of obesity in kids is going to be lower than if you use the CDC definition of the CDC 95th percentile. So the prevalence would be lower. But if you look at overweight or obese, the prevalence will be more similar, depending on the age. If you look at maybe 5-year-old boys, you might see a slight difference, but they're much closer than the obese cut points. There's another reference population. There are many other ones. I'm just showing you 3. So there's the reference population from WHO, and this is different. There's a growth standard from birth to 4 years of age, and it's based on data from the Multi-Center Growth Reference Study, MGRS. And there were sites in Brazil, Ghana, India, Norway, Oman, and the United States. Sites, they're not nationally representative data, but sites in each country. And the data are really based on optimal nutrition, environment, and care. It's more prescriptive than a reference, the way the CDC or the IOTF are a reference. This is more prescriptive, like this is how kids should grow if they're given optimal care and feeding, primarily breastfeeding. Starting at age 5, it really is a growth reference. It's data from the 78 WHO charts, which are really the US data that I've mentioned already. And then these 2 pieces of data, exclusions were made, and then there was a smooth transition between this standard and the reference. But many people do use this reference to define obesity. The cutoffs for obesity in the WHO reference compared to the CDC reference are a little bit different. As you know, the 95th percentile is used on the CDC, but WHO uses +2 z-scores, which translates to 97.7th percentile. And here's the prevalence of obesity in children 24 to 59 months of age. It's more than 10 years ago now, but you can see that the prevalence, this gets to the other thing about is the difference meaningful or is it statistically significant? So here the prevalence based on the WHO cut point was 8.5%. Based on the CDC 95th, it's 9.6%. So they're not too far off from each other. All right, so that's kind of thinking about the definitions and understanding that it's not just like we know, here's this we know the body fat here, or we know when risk goes right up. So, but let's look at BMI and body fat, since BMI doesn't measure body fat directly. This is a picture of normal weight, overweight, and obese children, and I show this, and I could show you adult pictures as well, because I think that often, especially when you look at pictures in the media, you see quite obese people, you see extremely obese people, and there'll be something that says they're overweight. Well, that's not, those people are not overweight, those people are generally extremely obese. But this shows you kind of what it really means in terms of actual kids. And you can see right off that it's not clear that the kid and the young girl in the center is overweight. I mean, she's overweight by BMI standards, but we don't know from this alone whether she has excess body fat. So there are ways to measure body fat directly, and one of them is a DEXA scan, and in Hanes we have included DEXA scans in certain cycles. So you saw every 2 years there's a cycle of Hanes, and different components go in and out of the survey. And if you then look at mean percentage body fat by sex and age in kids, this is data from 99 to 2004, you can see that from 8 to 19 years of age, that the girls, the mean body fat kind of creeps up, and boys, you actually see this drop. And this is typical and consistent with growth in kids. It's just the level, the question is the level. So there really isn't a set cut point on what's too much body fat. So how are we going to know exactly what the right, what the right cut point is? We don't have a set and agreed upon definition of excess body fat. But often, as with the BMI, we use some sort of reference population people will use to define excess body fat. And so that these curves are the smooth curves from the data I showed you on the last slide that sometimes people will use as a definition of body fat. But because we do know that there's been this secular trend in weight in the U.S. population, you would probably use a lower cut point for the cutoff. But you can see the boys on the top here in blue and the girls in pink. So how do the BMI and body fat compare in the same kids in a nationally representative sample? Okay, so this is the prevalence of high body fat or high adiposity among U.S. girls by BMI category and race ethnicity. And the age is 8 to 19 years of age, the years 1999 to 2004. And it's a fairly conservative cut point for body fat for a definition of excess body fat, and so we use the 70th percentile. And you can see a couple things here in this graph. So you've got normal weight, overweight, and obese. And the first thing you note is that in the obese group, the majority of those kids in the obese group by BMI have excess body fat. That's the first thing you notice. The second thing you can see is the overweight category. It's a heterogeneous group, and in fact, overall, maybe half have excess body fat by this fairly conservative definition. If we use a more liberal one, it actually goes down. And what's the other thing? The other thing is there are race ethnic differences in body fat at the same BMI level. And so if you see in the overweight category by BMI, remember that the x-axis is the BMI categories. So overweight by BMI between the 85th and the 95th percentile, that maybe a little over 25% of the African American girls have excess body fat in that category, whereas more than 50% of the white girls have excess body fat in that category. So there's this different. We don't right now, for this, we didn't have data on Asians, but now NHANES is oversampling non-Hispanic Asians. And we've had a 2-year cycle already, and we'll have another 2 years at the end of the year, so we'll be able to have, hopefully, good enough sample size of 4 years of data to really investigate that group more, because it's different in that group. So you might even, in some Asians population, find more body fat in that particular category. So there are just differences. Not everybody is the same. All right. Now we'll turn to another favorite topic of mine, measured versus reported BMI. I am a big fan of measuring whenever you can. So this is the prevalence of obesity among teenagers 12 to 19 years of age, based on NHANES in the green line at the top. And that compares to the prevalence of obesity in high school kids, grades 9 through 12, based on self-report. And adults look like this too. If you compare measured versus self-reported, you're going to have similar lines. And you can see that consistently, the measured, you get a higher prevalence of obesity. And why is that? Well, as you probably know, people misreport their weight and height. And what do? They underreport their height, particularly males, and they overreport, they overreport their height, and they underreport their weight. And so particularly males overreport height and females underreport weight, but there's misreporting in both men and women on this topic. And so, you have an interesting thing here when getting to the issue of trends. When you're looking at trends, and you're looking at trends in measured, and you're looking at trends in self-report, are you actually looking at the same thing? Because are the trends in the self-report really, are they measuring just that people are reporting better or reporting worse? Or it's partly the reporting. You have to make this assumption that the misreporting is the same over time if you really want to say that the trends are representative of the same thing. It's kind of an interesting thing. I find this whole issue of the misreporting very interesting. So. Now, what about little kids? Well, little kids can't report for themselves, so you can ask their parents to report. Well, I say this is worse than asking the person. So here we have, this has prevalence of obesity from 3 different surveys. It's got the measured data from NHANES. The data are from 1999-2004. It really doesn't matter the year here, because the point is the differences between them. And then there's proxy-reported data from the National Health Interview Survey, which I mentioned at the beginning, and then proxy-reported data from the National Survey of Child Health, which I mentioned also at the beginning. And you can see huge differences in the younger children. So the 2 to 3-year-olds, 4 to 5-year-olds, 6 to 7, 8 to 9, and even it's changing a little bit more. And by the time you get into the teenagers, it looks like the slide I just showed you on self-report. But you've got maybe 10% of the 2 to 3-year-olds, based on measured, of the national population are obese, compared to 50% from the National Health Interview Survey. And I remember getting a call from somebody who had been analyzing the data, and they were so excited to see this finding. I said, well, I don't think that's right. And so we've looked a little bit more at it, and what we have determined is that the misreporting is worse in terms of height for children. That the weight isn't so bad, but the height is bad. And so what happens, instead of over-reporting height, as adults do, it's actually under-reported, because kids grow so fast, and you might not know your child's height, whereas you're probably going to know your child's weight because you're going to give them medication based on their weight and so on, but you may not know their most recent height. And so because of the formula of BMI, weight over height squared, when height is underestimated, you're going to get an inflated BMI. And so we think that that's what's happening here for the younger children. Okay, all of that as the background now to talk about trends in obesity. So you all know this, but Americans are heavier in 2010 or now compared to the 1960s. And just to give you a sense of how much heavier, if you look at the average man, they're 30 pounds heavier. So the mean weight in 2007-10 is 30 pounds bigger than it was in the 1960s. In that early survey, remember 1960 to 62, 30 pounds. The average 11-year-old boy is 19 pounds heavier. And I could show you data for, different age groups, but, or different ages of the population, but that's what it looks like. This is a graph that goes back to when, at the beginning, where we have 1960 to 62, all the way through the most recent data. So these data would be for adults, the adult population. And you can see the prevalence of overweight is flat. Obesity increased between 1980 and the early part of the 2000s, and maybe beginning to level off more recently. And you can see the extreme obesity growing over that time period. Of course, looking at just prevalence just tells you one thing about one point in the distribution. I'm always interested in looking at the whole distribution. How does the whole population look? And this shows you the distribution. It's a smooth distribution of BMI in adults 20 to 74 years of age in 1976-80, right when we started seeing that big increase in obesity, where it started happening after that, to 2005-6. And you see a couple things. The distribution has moved to the right. The whole distribution's moved to the right, right? Our whole distribution's moved to the right, and it's become more skewed, so we have more people in the tail, too. So I think that this, in combination with looking at the prevalence changes, helps you think about the big picture of how things have changed. All right, so what about trends in the continuous survey? So this is looking at linear trends in obesity among adults over the continuous surveys of Haynes, 1999-2000 to 11-12. So there was an increase in men, but not women, between 1999-2000 and 2009-10. But for both men and women, between the 09-10 estimate did not differ significantly from the previous 6 years, from 03-04, 5-6, and 7-8. And so you can see this even visually, that there's kind of this increase here in the beginning of the continuous survey between 99-2000 and 03-04. And then there was no significant linear trend over the last 10 years between 03-04 to 11-12 overall in men or in women. So let's turn to children. So I showed you a graph of as far back as we could go for adults. So I'm showing you a graph as far back as we could go just for the 2 to 19-year-olds altogether. There were those surveys in the 60s, but remember they were age specific. So if I'm looking at 2 to 19, I can only go back to 1971, which is the Haynes one. What's the first thing you should note in here? Well, in 71, 74, and 76, 80, 5% of the population was obese. Well, that's by definition. Those are the data that were in the growth charts. And we're using the CDC growth charts here as the definition. And then similar to adults, we saw this increase in the 80s and the 90s, the early part of the 2000s. And this shows a distribution change similar to what I showed you in adults of BMI, and this is of adolescents 12 to 19 years of age. I don't think it's exactly fair to do this for this age group, but because of sample sizes, we needed to collapse the whole age range because BMI changes with growth in kids, and so 12 to 19 might be too wide of it to do. But I wanted to just show you that even looking at this kind of crude way of a BMI distribution of 12 to 19-year-olds of age, you can see a change in the distribution, a slight shift to the right, and it became a lot more skewed. And so in this graph, there's also the cut points for overweight. There's a line there at 25 and a line at 30. And you can see the area there under the curves getting bigger over time. And you can see the mean and the median BMI in 76, 80, and 2003, 6 there. So the mean went from 21.2 to 23.5, and the median from 20.6 to 22. So now let's look at the linear trends in obesity among kids over the continuous surveys. And similar to what we saw in adults, there was an increase in boys, but not girls, between 1999-2000 and 09-10. But also similar to adults, the 09-10 did not differ significantly from the previous 6 surveys, the 03-04, 05-06, and 7-8. And there was no significant linear trend over the 10 years from 03-04 to 11-12 overall in that period. So it was a very similar kind of thing to what we saw in adults. So I'm going to go back now to these questions I asked, or these points I raised earlier, to kind of remind us where we are. So the analytic decisions when you're analyzing obesity data and trends. So what definition of obesity were used? Think about, making sure that everybody's using the same definition. That you can see sometimes people using the IOTF and people making comparisons, and you can't just directly compare the estimates. Thinking about the quality of the data, the self-report versus measurement, and being care that the actual data that you're getting is representative of what you want it to be. And then the other things, thinking about whether we're looking at a total or subgroups, the sample size, trend, what years to start, and what test of trend. We're going to talk about that again, or more now. So there are lots of analytic decisions that are made in terms of looking at obesity prevalence and trends, and I'm particularly talking about NHANES data here. And one of the big things is whether you combine survey years. So I want to point out that the continuous survey is actually a pretty small sample. If you look at the 11-12 data, there were 3,355 kids, and only 565 of them were obese. And if you break it down by race ethnicity, you've got 728 whites, 1,008 non-Hispanic blacks, 404 Asians, and 1,035 Hispanics. And if you then look at the number of actual obese kids within that group, note that the non-Hispanic Asians, there's only 33. So this is for race ethnicity among the 2 to 19-year-olds. It's not even divided by sex. So think if you wanted to do it by gender, you're going to divide it in half. What if you want to look at it by age group, gender, and race ethnicity? Well, you're going to have a really, really small sample size. So I wanted to I think that this makes the point on, you can see how the stability of the estimates can be enhanced by combining survey years. And when a lot of the analyses we do just generally within NHANES, we use more than 2 years of data. To look at trends, it's probably better to use as many points as you can over the time periods you're looking at. But when you start wanting to get a really good estimate, you may want to combine survey periods. And so here you can see this is the 2 to 5-year-olds from 71, 74 to 11, 12. Remember, this is as far back as we can go for that age range. And again, it's about 5% back in the early surveys. And then you can see the increase. And then you see a lot of bouncing around with the data in the continuous surveys. And this is what it looks like when we combine and do 4-year estimates. And so that we have 9902, 0306, and 0710. The 11-12 data is just 1 2-year cycle. And I look at that as kind of a preliminary number, and then when we get the 13-14 data, we can get a better estimate for the 2 to 5-year-olds over that 4-year period. And then compare it to these other ones. But I think that, so thinking about when you're looking at subgroups in the population and you're looking at national data like HANES, I think some of the other surveys have much bigger sample sizes, but when you're looking at HANES, it may be better to combine survey periods when you're looking at subgroups in the population. Not necessarily for doing your statistical testing, because you might want to have as many points as you want, but for looking at the best estimate for the subgroup you're interested in. So there are also analytic decisions you make related to different time frames. And I can show you a great example of this. That 2 papers came out that looked at the prevalence of obesity, one in childhood and adult obesity, and the other just obesity in children. And there were 2 different time frames for these particular studies. So the objective on one was to provide the most recent national estimates of child obesity between 2003 and 2012, and the other was, let's look at NHANES and provide estimates between 1999 and 2012. The actual conclusions and relevance in terms of the studies were very similar. Overall, there's been no significant changes in obesity prevalence between 03-04 and 11-12. And the other one, nationally representative data do not show any significant changes in obesity prevalence in the most recently available years, although the prevalence of obesity may be stabilizing. I'm not sure, anyway, the sentence needs to be fixed a little bit. But let's look at the actual tables, so kind of get into a little bit what the studies are. So you can see here, this is the unadjusted linear trends, test of linear trends in obesity, and I circled the 2 to 19 years of age. And you can see that the p-value for a linear trend there was 0.78 over those 10 years. And then here, if you look at the trends from 1999-2000, the p-value was 0.03, so that it went up over those years, or it was level over those 10 years. And these are both true. These are both accurate representations, because it just depends on the time point that you start at. So just to give you a little bit closer look at these, remember that this is all the data we have on kids from 2 to 19 years of age, back to 70, 71. And you can see a lot of that noise in the more recent years. And if you look then here from 2000 to 11, 12, that really if you include these 2 points, that they're really driving that, this trend here is because of those 2 points, but that these points there's no difference between them. So it's just a matter of what time period you're going to look at. And this is the trends in extreme obesity prevalence over the same time period. And you can see here that in 9900, it was 3.6%, and then over this time period, there really hasn't been a change. And so that there is a linear trend over the 14 years, and it's significant, just barely. But if you look over the last 10 years, there's no significant change. So the time point you start with is a really big determining factor about what trend results you have. What other analytic decisions? All the data or point estimates? Are you going to do a linear trend or a quadratic trend? Well, you can model all the data, basically fit a line to the data, which we often do. You can model the data and fit a quadratic curve, or if it looks like a curve. But you can also use point estimates in things like the join point analysis if you have enough data points, and you can find out where changes might have occurred over a time period, and then estimate kind of linear changes before and after that time period. But you need to go back, at least with the survey data like HANES, to go back to the actual data to estimate the slopes of those changes. For HANES, we don't do this second method very often because we haven't had enough points over a consistent period of time to really do that well. But I see people kind of investigating this more now. Oh, so what about doing an unadjusted or adjusted trends? What's the right thing to do? Well, obviously, they both are going to provide you with different information. I've kind of come to the conclusions it's good to do both and to provide both. So this is looking at the linear trend in obesity among U.S. women 2003-6 through 2011-12. And on the left side, we have the absolute change and then the p-value for that change. And so that you can see for women 60 years and older, there was a 6.6% increase in obesity over that time period. I don't see this out in the media so much, but this is what happened. And the p-value was 0.005, and that's the unadjusted or crude trend. So this is like the burden in the population. But the adjusted trend, when we adjusted for race, Hispanic origin, and age, also for the total, you can see the p-values as well. The p-value for the older women is still significant at 0.01, and the others are not. So just to give you a little flavor of what one little example of looking at unadjusted and adjusted trends. But this is, again, just an analytic decision that the person would make about how they're doing trends analyses. There are also, in this whole conversation, external forces at work. And so I just thought I'd point out a couple things related to the two studies I just showed you that really just looked at trends over different time periods. And then there were different press releases that went out related to them. And they're all accurate, though overall obesity rates remain unchanged. Rates in young children improve or may have improved. Obesity rates on the decline or may be on the decline among young children. And that finds all classes of obesity in children have increased over the last 14 years. So all of these were, accurate to and related to the study. And of course, then that comes out in the media. And so we have the first article, obesity rates for young children plummets, 43% in a decade. And when I'm reading the article actually was very accurate. I didn't have any trouble with the article. I think different people write headlines. But then you see later on that obesity studies tell two stories, and they're both right. And it's because of this issue. You can do trends differently, and they're absolutely, both were right. All right, so let's go back to kind of like, what are the main points that I hope that you get from my many words. Defining and measuring obesity. BMI is not a perfect measure of body fat. There's no universal definition of too much body fat. Measuring is much better than asking. Small errors in measurements can have big effects on estimates in young children because you can see how much just a small change in weight could move the BMI. And so being attention to that detail, I think, is really important. The definition in children is statistical, and there are various reference populations that are used, primarily the CDC growth charts in the US. NHANES, it is the gold standard for national estimates, and it's, the quality of the data is excellent. I mean, I'm really proud that we as a country have this great survey. I think it's great. It's nationally representative. It's publicly available, which is great too, but you can then have different analyses on the same data, and you can have overlapping publications. And I actually was going to do a PubMed count on the number of publications from NHANES on obesity. There are a lot, but I didn't have time, I'm sorry. But there are some limitations to NHANES. It's released only every 2 years. They're very small sample sizes, and especially for demographic subgroups. And so that may be, for some estimates, you would want to combine a survey, combine 2-year surveys and get a 4-year estimate for some subgroups when you want estimates for a small group. Or if you're looking at rare events, like in this case, very high cut points for obesity. You want kind of the numerator to have some people in it, right? To get that estimate, you might combine years. What about the trends? Well, what time period are you going to look at? What's the question you want to answer? And what time period are you going to look at? Are you going to do a linear test? Are you going to do a quadratic test? Are you going to use all the data or do point estimates like using something like join point? Are you going to do unadjusted or crude trends? Or are you going to do adjusted trends? So there are many, many questions to answer there. I want to thank all of my great colleagues and present my disclaimer from CDC. And thanks very much.